Hey, Antonio.
Hi, hi, Zach.
How you been, man?
Good. How about you guys?
Good.
Share to
Hey Antonio, how you doing?
Henry. Nice to see ya. There. Great.
Is this an ultrasound artifact I'm not aware of, what we're seeing on the screen right now?
What are you guys seeing?
No, just the rows. It's like an optical illusion.
The
I was,
road.
I was gonna say the same thing. That's a pretty neat power slide there.
Oh, the back one. Yeah.
Yeah.
Just pick a random template on PowerPoint with nice colors.
Antonio, I was going to shoot you an email. We got revise and resubmit for the femoral nerve block. We just got an email from them yesterday. Yeah.
That's great.
Yeah, no, I'm pretty stoked.
That was pretty quick turnaround. That's wonderful.
Yeah, I thought so too. Um, so a number of things they want us to look at, but all pretty doable. So yeah,
Perfect.
yeah.
I have no nerve block cases to present.
Okay.
Tons of other wild stuff though, I think.
I've been bad. I don't know if I've been working a lot of Thursdays or what, but I'm ready to get back into it. I need to do some learning.
Will do my best.
Okay. I know you will.
Antonio, how's your volumes in New Haven doing?
They've definitely picked up. I was chatting with Aaron a little bit about that last conference. Respiratory cases are certainly up. It seemed this past week seems to mellow out a little bit. I think some of that might just be holiday effect, maybe. Like croup asthma, bronchiolitis. Seems like it's in vogue in June this year.
I agreed. Yeah. So that's where we're seeing the rise in the bronchiolitis cases. So looks like we're a few months off.
Yeah, we're the same thing. I'm really curious when it gets back to fall, when it would be RSV season, if we go back to historic seasonality, or now the virus has discovered hey, summertime's nice too. It's just going to be some weird year-long shenanigans.
This coming from the guy who never sees snow, right?
We actually had snow down here the first year that I was here. Shut the city down for a week. Hilarious. It was 2 inches and nobody knew what to do with it.
Those terrible winters down there.
Yeah, no, seriously. I grew up in Western Colorado. I've had plenty of snow.
Should I jump in, Henry, or give it a little bit more time?
Now we're just gonna give it to 1:05, so just another minute. That way, give people some time to jump in, and then you can take it over. So.
Hey Henry, how's it going? Just saying hi.
Hey Rahul, how you doing?
Good.
Look so different now that you're an ultrasound fellow,
Do I?
Yeah. Look a lot wiser.
Mhm.
All right. It's 1:05, so thank you everyone for joining us Thursday. Today we have Antonio. from Yale presenting to us. So go ahead, Antonio. You can take it away.
Awesome. So we'll dive right in. I want to try to present, be consistent in my turns, and just not go too far outside of the box, and just put together some cases where POCUS was really instrumental in patient care, perhaps for some from more bread and butter applications, and certainly the things that uh, my favorites, which would be patients that present with respiratory distress without a clear etiology, clear cause, anything soft tissue. I love POCUS for trauma. And then from a belly standpoint, in terms of imaging the belly, I feel like some high yield applications include patients present with new or unexplained urine retention, and then abdominal pain, but not just abdominal pain. Abdominal pain with a distended abdomen tends to give a higher yield in terms of findings for point of care ultrasound, in my experience. And there's a lot of clinical pearls, and I think some admin issues that might lead to some discussion amongst the crew. And I got to start with just a wild case from this week, just like one of these that there's no way I'm going to see something similar to this again in my career. And it's one of these where early morning, sort of 9 o'clock, not that busy in the ED, freshly minted PGY2 pediatrics resident and myself are sort of manning the board. And we get a call in from a patch that there's a 2-day-old at a pediatrician's office in respiratory distress. And so this baby had an essentially unremarkable newborn history, 38 weeks, 4 days, NSVD, mom was GBS negative. They were first-time parents. Seems like they got out of the hospital pretty quickly. And on that follow-up checkup, there seemed to be some facial cyanosis and hypoxia. Hypoxia reported to be as low as 30% in the pediatrician's office. Came in with first responders on blow-by, and arrived in our major treatment room crying, pretty noisy, agitated, did look pink at the time. And we hooked this 2-day-old up to the monitor, and the vital signs are pretty reasonable. I mean, heart rate 140. The respiratory rate I clicked down as fast because the what was documented in the chart initially was in the 30s to 40s range, but this newborn was breathing faster than that. And, I'm thinking, oh, this has to be cardiac all the way, cyanosis, hypoxia, 2-day-old, it's going to be a coart, or it's not a coart, it's going to be a PDA or some congenital heart disease. So we do the usual, lower leg blood pressure, pretty good. We get oxygen saturations in both the hand and the feet, because I didn't really believe that it was 30% initially, because again, this baby's crying and pink. And sure enough, with a good tracing, it's 30% in the upper and the lower extremities. Baby's grunting, there's some accessory muscle use, and pretty reliably thought there was no murmur and had some good pulses. So placed on 100% non-rebreather right away, and the sats come all the way up. So down from like the 30s all the way up to the mid 90s, high 90s. And we the first step, of course, is point of care ultrasound. So, what am I looking for cardiac standpoint? I mean, I think just big picture stuff, just trying to get a sense of normal anatomy, I guess, for a 2-day-old. Function, of course. Here we have a parasternal lung. Function looks pretty reasonable. RV is about 1-to-1 here. I think I haven't done too many cardiac ultrasounds on 2-day-olds, to be honest with you, but this is probably my guess appropriate for age. So that looked pretty good. Move on to an apical 4 subxiphoid, just again to get a general sense to make sure there's nothing too abnormal from a congenital heart disease standpoint. And this looks like a pretty typical 4-chamber-ish view with a descending aorta there. Anything else jump out at anybody on this clip? I mean, the only other thing for me is maybe there's some B-line artifacts down here. To be honest, at the time when I'm looking at this image, I was just looking at the heart. So I don't think that jumped out at me as I'm scanning. Moving on, IVC, hepatic vein coming off right here. Looks pretty flat and collapsible. So at this point, I feel pretty good that this baby is not in heart failure. And again, the respiratory exam was difficult just because was crying and grunting, so it was just hard to like appreciate reliably the auscultation findings. All right, so next step, move on to the lungs, and we have the probe, which I switched out to the linear because initially I just did a phased array probe in the apices. And it looked fine, but this kid was acting so sick, it didn't make any sense. So I switched to the linear. I just like the resolution so much more. And then what do you got? What would you say here? This is the right side, mid-axillary sort of, I mean, the probe basically covers the entire thorax for a 2-day-old. So mid-chest, mid to lower chest. What would be your interpretation? Anybody?
Certainly seems like some fluid at least.
So we got definitely some confluence of B lines here, and it looks like it's across 2 different rib spaces. So B lines here, B lines here. So I said, okay, now we're getting somewhere. We're finding something abnormal to maybe explain this baby's symptoms. He's acting so sick with that such severe hypoxia. And then I move over to the left side, and we got this. Anybody want to take a stab at this one?
I don't know because of the solution, Antonio. Is there? Does it look like a pneumo? I just can't tell just because I can't see the ants marching.
Yeah. So it's exactly what I thought. I was like, what is this just a pneumothorax here? And then this is left-sided lateral mid-axillary. This is the transition zone here. We got diaphragm, we have spleen, and we have maybe the suggestion of some B lines right at the beginning of the clip here. And everything else just looks white up here without any sliding at all. So I saw no sliding here, no sliding here, no sliding here. And I said, this kid's got a pneumothorax. This is a 2-day-old with a pneumothorax. And it's not just a small pneumothorax, it's a big pneumothorax. And I tried to put him on M mode, but the kid was moving so much and crying and so hysterical. I really couldn't, like, there was too much artifact. So I couldn't get a good barcode sign on motion mode. So, you know, the portable
Dr.
chest
Riera,
section.
I'm sorry to interrupt. On your IVC view, I did not see a plethoric IVC. Just keep that in mind when you talk about whether or not this is a large pneumothorax or something else.
Yeah, I think that's a great point. We'll see how this case evolves, but not tachycardic, you know, good blood pressure. And I just think if I see absent lung sliding up here, you know, that could be a tiny little spontaneous pneumo. If I see absent lung sliding, perhaps where I'm considering placing a chest tube, you know, I think that from a quantitative standpoint by POCUS, that might suggest a more serious process going on. But you're right, that IVC was completely flat and collapsible at the time. So we get the X-ray, and this is what we get. What do we think? Well, I know this is ultrasound conference, and I don't want to take up time with silence, but we were wondering about lucency over here. You know, there's definitely seems to be some haziness through all the lung fields. And I called the radiologist, and they said, yeah, you know what, maybe that's a pneumothorax. It's hard to quantify it. But that certainly looks more lucent and without any air markings there. So, you know, I got a 2-day-old that I'm real, and by this time respiratory was already in our major treatment area, ready to hook this baby up to a high flow nasal cannula. And I'm really doing everything in my power to potentially stabilize. We have vital signs. We don't have hemodynamic collapse yet. So I'm trying to not have to intubate a 2-day-old. And to be honestly, I'm probably going to call the NICU as the single physician, again, with a pediatrics resident helping me out. So this prompted a phone call to our surgeons, and I said, I have this sick baby, very hypoxic, 30%. Looks like a pneumothorax on X-ray. I can't quite understand. It looks kind of small on the X-ray, but on my lung focus, I see no lung sliding at all on the left side. I'm actually worried this might be a tension, or it's starting to be turned into a tension. And this was a direct phone call to the attending, and the fellow picked up, and I had the conversation with the fellow, and the attending was probably tied up at the time, and he suggested we repeat another X-ray, and they would get down to the ED as soon as possible. So we get a repeat X-ray, and we have this. So at this point, this is probably 30 minutes later in between the two films. And we had done nothing other than support with 100% non-rebreather. At this point, you can see a much more marked pneumothorax with the outline of the lungs, with clear mediastinal shift, tracheal deviation, and the heart contents over here to the right side. And the radiologist called pretty quickly, and they said, yeah, this is a tension pneumothorax in this baby. So lo and behold, never placed them on high flow nasal cannula until after the pigtail catheter. And that X-ray really got the surgeons to the bedside pretty quickly. Post chest tube placement, we have this. So essentially we have what we were seeing on the right side, on the left side, and just confluent B lines everywhere, interstitial alveolar findings in the context of a 2-day-old with severe respiratory distress. This was felt to be due to respiratory distress syndrome and surfactant inactivation, surfactant deficiency, and a 38-week 4-day-old. And I couldn't even remember the last time I had to deal with surfactant deficiency in a patient that I cared for, to the point where I even asked the NICU team, can I just give IV surfactant? And sure enough, you can't. So after the pigtail, placed on high flow nasal cannula for additional stabilization, got this baby up to the NICU, was intubated there so could get endotracheal surfactant, had a pretty good response to that. Normal echocardiogram, and then subsequently grew some Citrobacter strain from a blood culture, and had a brain MRI because there's some association with brain abscesses and Citrobacters and neonates, Citrobacter infections in neonates, which is certainly news to me. So anyways, for me, POCUS in this case was incredibly valuable. And I think one of the most valuable aspects of it, to be quite honest with you, was after the surgical team was done with the chest tube placement, is we sort of just went over the images together, and I said, listen, this would apply the same in our trauma patients. If I don't see lung sliding in the mid-axillary sort of lower thorax area, I think we have to start thinking about getting ready for, chest tube placement. Again, this is pre-tension, like what we are taught is tension physiology, right? No hypotension, no tachycardia, no plethoric IVC. So ultrasound gave us an insight into what was going to happen next early on. So I thought this was super, super cool. All right, so that's it for the respiratory distress. We'll do some skin and soft tissue. This is a case of a 10-year-old who presented with her mom after about a week or so of swelling to the breast tissue. And it was pretty impressive amount of swelling, as you can see on the picture there. She had been afebrile. There was no drainage from the areola, from the nipple area, and she had already been taking Bactrim. Never had an abscess before, although she dealt with hidradenitis, and there was a family history of MRSA. And so the physician at the referring hospital, just based on physical exam, made a judgment call to perform an incision and drainage procedure for what they thought was likely an abscess. And so what happened was that there was bloody drainage, no purulence, and it was still oozing quite a bit. So they decided to pack the incision that was made. And then they sent to us for further evaluation and care. And so, of course, the first thing that we would do is ultrasound. Certainly the first thing that I would do after examining the patient is do ultrasound. We were very sensitive to this child's age and the inflammation, and certainly the modesty of everything. But she was such a trooper. We used tons of gel here to get a good look at the tissue. And this really correlates with the probe being right over the midline to the breast area over the areola. So I thought, well, maybe they just missed the abscess pocket. Let's move over here. We saw a lot of tissue echogenicity. We see a dark lesion in the center of the screen there, which is always tough for me. And I don't image it. I don't image breast that often, but I always debate, is that a vessel? Is that a duct? I think this is a pretty challenging POCUS application overall. However, put some color Doppler on it and probably a vessel. So at this point, the probe is still on the midline. And in my mind, this is mastitis, IV antibiotics, we'll consult additional services as necessary. But just a gentle sliding, a lateral slide of the probe to the right, and this is what was there. So, clearly a very large heterogeneous collection, posterior acoustic enhancement over here. And you at the beginning of the clip, you don't even have to push down on the probe. You can see the contents swirling, a little bit of a little swirl right there. So it's all about probe positioning. Called the surgical team and we did a sedation, procedural sedation with ketamine. And for breast abscesses, first line is aspiration. This pocket was so, I think, thick and inspissated. I think that's a word, right? Inspissated. It was really difficult to withdraw any of this purulence from this abscess cavity. It was so big. And so, again, we got to collaborate with the surgery team. We did inline approach. You can see the needle coming in over here. And probably a little bit steeper angle than we're used to doing, because the proceduralist is not holding the transducer in this case. But we were able to know we were in the right spot, and it was being too difficult to drain this very large infection. So it had to be converted to a vessel loop drainage procedure, which a copious amount of drainage was obtained. And this was the end result. We were able to at least guide the entry points of the pocket. And this is the residual, this is the post. So it wasn't completely drained. Again, posterior acoustic enhancement, some inflammatory changes. And just look at where the abscess pocket was over here relative to where that first incision and drainage procedure was done. So always look before you cut. If I'm gonna do an IND, or if I'm debating to do an IND, even if it just seems like it's so obvious that the collection is so big and you can palpate and there's fluctuance, I'm always gonna take a look first. She did quite well. She grew MSSA, interestingly enough. We did keep her for overnight monitoring just to make sure that we could treat some of that secondary cellulitis, and eventually was sent home on doxycycline. And that vessel loop actually came out in 5 days in surgery clinic.
Antonio, can I ask a quick question?
Yeah.
I feel I was always kind of taught to be exceedingly resident about cutting or doing anything really to the breast tissue. Is this it? Do you guys not? I don't know. How frequently are you guys doing procedures in that area, and do you not, I guess, share that reticence? Or
I would say never, for myself personally, in terms of going at it, but with the PEM team alone.
yeah,
This was a tough one because there was conversation about OR versus bedside, and so those are some of the challenges, I think, secondary to the image interpretation that come into play. Our surgical team felt like they could manage this with adequate sedation in our ER. So we had a conversation with the family about it. And yeah, for us, breast, not just infections, but any concerns for breast pathophysiology or breast lesions, we're having radiology do diagnostic ultrasounds to differentiate ductal, ductal involvement versus breast tissue.
Yeah.
This one was so it was just so large, and if you go back to the initial this, it was so superficial. It was right there under the skin. That in this particular case, we sort of just went with focus, and the surgery team was comfortable with that. But I'd certainly encourage us to think about radiology, and maybe some hospitals have like a specific breast team that can take care of some of these cases. We sort of have, but it's run by adult surgery. So in this case, we reached out to the pediatric surgery team, just given her age, and the attending, felt comfortable caring for her. But great point, Zach. All right, so here's another kid I had not too long ago, 10-year-old male, who unsure quite exactly what the heck happened at his home, but he somehow found a way to get a plastic antler from some sort of carnival prize, moose head or something like that, impaled into the right side of his leg. So he essentially presented with this thing impaled into the leg, wrapped up with Kerlix by the first responders. And, it seemed like it was stuck. It was embedded pretty tightly initially, and he was neurovascularly intact. And it was an isolated injury. I think he tripped and it was on the ground, and he sort of just fell on it just right. And so as we're doing the secondary survey, the thing just it actually just slid out. So it didn't take any amount of force to yank it out. This kid was freaking out, so anxious. We put some lead on. We order an X-ray to see if there's any residual foreign body. And what we had them do is we had them place the antler next to the bed. And I told mom, make sure that they put that antler piece next to the bed so that we know if you can even see any residual piece by X-ray or not. So this is the X-ray, and it was read as a soft tissue laceration. You can kind of maybe see a little bit of air here, maybe a little bit of air here. No radiopaque foreign body. So, I was genuinely worried that there might have been a piece retained. And if you look at we looked at this pretty closely, and it looked kind of jagged and irregular, and it was hard to know if there was a residual piece left inside the leg. So I brought out our ultrasound machine, and we took a look near the wound, not directly above the wound, but near the wound, as the probe would suggest here. And we saw echogenic area right above the fascia in the deep dermis here, with some shadowing artifact. And so if I see something in one plane, I want to see it in another plane. So rotating the probe about 90 degrees or so, again, you can see some little shadow artifact, this echogenic up here. We measured it less than a centimeter. And so what do you guys think? How would you interpret this one?
And I would be definitely concerned, like you said, of retained foreign body in that area.
Yeah, so I was certainly leaning in that direction. I had a little bit of hesitancy, but I was leaning in that direction. And then, so what I ended up doing was having a conversation with one of our radiologists, and we do have the ability for them to see our images as long as they're either clinical or procedural scans. So this one, because it's a foreign body evaluation, it's one of our procedural scans. And so our radiologist looked at it and he said, you know what, it could be a foreign body, I agree. The other option is that it could be an air artifact. So, why don't you repeat the scan and see if it's still there? So I said, that sounds like a good idea. Let's do that. So I repeated the scan a couple hours later, and here we go. Echogenic, same spot, right above the fascia, and we got the shadow artifact there. You got the soft tissue here. So, in good faith, I couldn't say that there wasn't something retained. It's relatively superficial. We're talking about a centimeter deep. Had a conversation with the mom about, washing out that wound and seeing if there's anything that we needed to retrieve. And so what ended up happening was that, we did local anesthetic and we did some midazolam for anxiolysis. And this is a short access view of, it was hard to get inline for something like this. So we had the we had a syringe filled with local anesthetic. We'd already numbed up through the superficial area. And we tracked it towards that area, that artifact, to see if you could feel anything gritty or, certainly something that would suggest that there was a foreign body there. And we never had that give. You never had that sort of sensation of something which is not too small be present there. So we did a local anesthetic, and then this area turned into this here. So if you can see right above the muscle and the fascia here, a new small area that's now more fluid filled, more anechoic, and this artifact went completely away. So we no longer saw the shadowing. We always talk about dirty shadowing versus clean shadowing. To me, honestly, I love to call this dirty shadowing in retrospect, but it looked like it was coming down all the way to the bottom of the screen. So this was actually air that was just trapped in that area. We did a referral for the child just because he ended up going through probably a lot from a mental health trauma. The procedure wasn't all that much fun for him either. Put him on some cephalexin prophylaxis. And I did a phone call follow-up, and mom was very happy. He was doing fine. He was running around. He was great. And so our conclusion from a POCA standpoint was that was actually air, as opposed to a retained foreign body. So, in this one, I have to be honest, sometimes I'm not sure, how to quite explain findings by ultrasound. And it's nice to be able to have a resource, somebody else to be looking even over my shoulder just to talk things through in real time. So I think I would have done everything the same way again, but it was just nice to have somebody to talk it through with, who also, I think, shared some similar doubts about potential causes of the ultrasound findings. And just for comparison's sake, here's another one with some similar ultrasound findings, also skin and soft tissue, very different case, but this was a 20-year-old who was breaking up two dogs fighting, and she sustained a bite mark to her wrist area and her finger as well. But the family brought her in sort of like the next morning. She broke up the fight the night before. So this was probably like the next early afternoon because of an area of redness, cellulitis, and here's the puncture wound here. And then we looked with ultrasound, and this is what was, I actually, I'll take a pause back. The X-ray resulted before the ultrasound. There were some findings on this X-ray here, like subcutaneous air, that our radiologist actually read as gangrenous cellulitis, which sounds kind of terrifying to me. I mean, the exam, and her flexion and extensor function was okay, but we had this X-ray and it had these little pockets of air, and the radiologist got worried about gangrenous cellulitis. So we get the ultrasound machine, and sure enough, you can see these little bright echogenic areas of air in the soft tissue here, up here, with shadowing artifacts. And clearly this is different than the other case because these are smaller little punctate pockets, and they're distributed a little bit more broadly as opposed to focus in one area. But you can see a very similar appearance of the bright air echogenicity with the shadow artifact deep to it. And then in this case, it ended up being different levels in different planes. And so we just did a check to her tendons here just to make sure that it didn't seem like there was a lot of fluid collection. Again, from a synovitis standpoint, her finger flexion function was okay. Did do a hand consult just because of the extent of this injury from a necrotizing infection standpoint. And, they actually went ahead and did an incision and drainage procedure. We admitted her for unison, and she seemed to do okay. And she got discharged within 24 hours. But fairly similar findings. So to the prior case, so I just think if sometimes, especially when there's an open wound, we might be fooled into thinking that there may be a retained foreign body when in fact what we're seeing is an artifact related to air being trapped in the subcutaneous tissues. So I thought those are super cool cases. Diving in a little bit deeper to some deeper soft tissue, we have, yeah.
Antonio, Will wanted to know what's the treatment for a real antler.
Deer antler impalement treatment. What would be the best antibiotic? Oh, real antler. I will phone a friend on that one. I don't think I have much experience with wilderness medicine to that extent, but I usually go Augmentin. Seems to be some Pasteurella strain in animals' mouths. All right, so this 20-year-old was referred to us from a university health office to Valley for a PTA, and he had a tonsillectomy when he was younger, but he presented with 2 days of symptoms. He did have a bit of a muffled voice and some sore throat, some pain with swallowing, but he was afebrile, and on exam he did not have trismus. You could get a pretty good look at his oropharynx. I would say it was probably asymmetrically erythematous on the right side, but the uvula was midline. And the clinician at the university hospital sort of put them in a state of panic, him and his parents, because they sort of posited as this was like a deep infection that was going to spread and needed to be drained right away. And sort of this is the mental model of the patient. And then to make matters worse, the father was a lymphoma survivor, and he presented with like a neck swelling, a lymph node, and things like that. So that this kid might have cancer presenting all of a sudden. So what we did to start was a transcervical ultrasound. So I like to start for these. I know Adam's a big teacher of transcervical ultrasounds for PTAs, but I like to start on the unaffected side, and I like to go things through with patients and their parents. So indicators here to the right. This was his left side. Submandibular gland here, and this is the tongue. The tongue looks fairly bright by ultrasound, and I usually have the patient move their tongue, and then this moves over here. So it's kind of like a neat thing to start with when we're looking at the images together. And I really like doing everything very sort of actively, and I talk things through as I go. In general, I find that to be a more appealing experience for POCUS scans. So put some color Doppler. I have no idea what I'm looking at here. There's some vessels lighting up here. This is probably artifact from the probe moving a little bit, but I certainly don't see any tonsil on this side. Maybe this is tonsillar tissue here. It doesn't have that typical appearance. And this is my contralateral. So this is my control. And then I move to the right side, indicator to the right, indicator to the right. We have submandibular gland here. We have the tongue on the opposite side now. And we have what looks like something might be brewing here in this patient with a little anechoic right here. There we go, reset. So, you know, I mentioned to the family, I'm like, I actually think he probably has a little fluid collection there. You know, this is a case where ENT was actually consulted before I examined the patient and met the family. So the phone consultation request was to get a CAT scan. So what what I try to do in most instances for some of these like peritonsillar infections is to as much as possible avoid irradiating the thyroid. So I really like to try to manage these without CT scans of the neck, if at all possible. We took a look. I think there's a fluid collection there on the right side. Could you please try to do an ultrasound first? You know, we spoke to ENT, they wanted some imaging. Could you please get an ultrasound first to see if you can also see that fluid collection that I'm seeing? And then, so they did an ultrasound of the neck, but they kept their images fairly superficial, and so the report came back as adenitis. So lymphadenitis on the right side there, and no fluid collection. White count wasn't that bad. Made ENT take a step back and feel like they had nothing else that they needed to contribute in this case. So what I told the family was, listen, I think that there's lymph node swelling. I know you're worried about lymphoma. This is very unlikely that this is cancer. We looked at this image together before on the screen. Like, I really think that there's the start of an infection there. It might not be in the posterior tonsillar area. It might not be like yet an abscess that needs to be drained, but I think it's enough that needs to be treated with intravenous antibiotics. However, the formal ultrasound was read as no abscess. So we went through the discordance between our findings and shared decision-making with this young adult and his parents, and they were completely on board with the plan to come in, be monitored, and then perhaps have to do more advanced imaging like a CAT scan should he not get better. And I bring this up because I think there's plenty of literature to support the management of peritonsillar infections and sometimes even peritonsillar abscesses with medical therapy alone, as opposed to surgical therapy. And this particular paper I just put up here because the only difference was that the surgical group required more opiates. Those that had an IMD performed had more narcotic exposure than those that were treated with medical therapy. So this young man did fine. He was discharged feeling better. I don't know what's the magic number in terms of when you're sort of confidently feel like you're over the hump and can transition to oral antibiotics, but he had no further visits with us, so I feel pretty confident he did okay. And then I know this came up recently at our P2 conference, transcervical ultrasound for diagnosis of PTA and the pediatric ED. You know, again, this was radiology performed ultrasound. And so, you know, throughput is faster. There's less radiation and it's less expensive. So that all makes sense, right? But our shop actually doesn't do this. So routinely. And even when I sort of try to have a conversation with one of the technicians about it, you know, I think the image acquisition plan was different than what we had done at the bedside. So I struggle with this one because I feel this one for me is sort of procedurally related. Again, if I'm going to aspirate an infection in the peritonsillar area, I'm gonna want to get some confirmatory imaging most likely, unless it's such an obvious, you know, huge bulging, uvula deviation, trismus, can't swallow. I think those are a little bit different, but you know, I don't know if others out there share similar experiences or consternations or.
Antonio, how old was this patient? Hello?
I think he dropped, I think.
I think it was a 20-year-old.
I was wondering if they would have tolerated the endocavitary probe rather than linear probe.
Julie, do you guys have the intracavitary probe available?
You know what, we have them on the adult side and we can use them. But you know, like just the culture of our pediatric emergency room, we're not generally doing them, but I know for sure, you know, on the other side of the ED, you know, they're doing them on the adult side. I'm curious if other shops are doing what Zach said in the intracavitary for PTA, and if your radiologists are doing transcervical for a PTA diagnosis.
I think it's a really good question. I don't know how my radiologist would react if I asked for them to do a transcervical ultrasound. That's a good question. We have the availability of.
Sorry.
No, I was gonna say we have the availability of both, and you know, usually it tends to be pretty straightforward. I would say if you're able to kind of, you know, identify the structures, but then to Antonio's point, there was a discrepancy, so maybe it's not so straightforward, you know.
Yeah, Julie, in our shop, I think it's operator dependent. There's some techs that are comfortable like just increasing the depth and looking at it deeper, but it's very like rare. And then for the most part, they don't do the endocavitary probe. Particularly, I do endocavitary probes all the time, and then ENT looks at the images and sort of confirms as well. But the one thing that I have struggled with, and then Rahul, something that me and Adam talked about doing study on was like there's sometimes small fluid collections. It's like what is that you can see on the transcervical approach, but then you got to decide how big does this have to be for you to drain again. Like I've definitely seen ones where I know there's a little bit of fluid that I have sent home on clindamycin just because I don't think it's worth it, you know, the actual incision and drainage, especially when they're like 12 and they're unable to open their mouths at all. But that's something that I know I talked to Adam before, but we felt like there's not as many people as we want doing this, and obviously we don't have as many PTAs, so that will make the study hard to do.
Yeah, I mean, I think I've heard Erica talk about this. You know, the transition from tonsillar cellulitis to tonsillar, you know, abscess phlegmon to peritonsillar abscess, and I think in those like kind of intervening stages, to your point, Henry, you know, it's not uncommon to see something that looks like a, you know, hypoechoic pocket, you know, but does that mean it needs a needle stuck into it at that point, you know?
Yeah, and I think in that like gray spectrum transitionary zone where it becomes like where it goes from you know, cellulitis to phlegmon transitioning to abscess, you know, I think a lot of ENTs do admit for IV antibiotics and reassess, especially in the pediatric population.
Which I think is a good idea. I mean, that makes total sense to me.
Will, what is the culture at Cohen's in New York?
We don't have endocavitary available, and yeah, I don't think specifically for the identification of a PTA, you know, we get, you know, soft tissue ultrasound next from radiology. At least other people do, looking for lymph nodes or differentiating, you know, just swollen neck, so to speak. But I doubt, you know, firmly identifying PTA would they would be comfortable doing that, or at least I think our techs are amazing enough that I think we can probably transition to that, but they probably need a lot of more convincing.
I'm thinking because of the storm, Antonio lost power because I was losing power yesterday intermittently.
Oh, the storm. Yeah, I texted him and I'm waiting to hear back.
He's the one who has like internet problems to begin with, isn't he?
And don't blame it the fact that he's a PC guy, because I'm a PC guy. Because I always blame him because he's PC, not an Apple guy.
It is him though, right? I'm not making that up.
I think so.
Ah.
It's-
Yeah, I seem to recall him having connectivity issues last time he presented.
All right, I might sign off. It's nice seeing everyone.
Yeah, Zach. Yep. Nice seeing everyone too. And just I'll probably announce this in the next couple of weeks as well. But just since we have a couple of times here that we'll be taking a break just to for vacations and everyone sort of going places. August won't have any sessions just for the month of August, and we'll come back in September. And then I'll be sending out a survey. Being that is this conference is a little a year old already. We passed June was our sort of like anniversary, so just some feedback survey that you'll receive from EBS Survey Monkey in the next couple of weeks. So, but yeah.
Thanks, Henry.
Well, thank you, Julie. All right. Well, have a good day, everyone. So I'm pretty sure Antonio will come back, and then I'll just wait for him to let him know everything's okay. But thanks everyone for joining, and I'll see you guys next week.
Bye, guys.
See you, Henry.